body identified something different. So I am excited to know that you all have really prepared for class today. We're going to start the lecture on what is diabetes. Diabetes is a disease that occurs when your blood glucose is high, when it's too high. It's your main source of energy, and it comes from the food that you eat. Insulin, a hormone made by the pancreas, helps glucose from food to get into your cells to be used as insulin. Sometimes your body doesn't make enough or any insulin, and it doesn't use insulin well. So glucose then stays in your body and doesn't reach your cells. When sufficient glucose and insulin are present, protein breakdown is minimal because the body is able to use glucose and fat acid as fuel. In children and adolescents, insulin is needed for normal growth and development. But because cell membranes are impermeable to glucose, they require a special carrier. And this carrier is called a glucose transporter, and it moves the glucose from the blood into the cells. Although several hormones are known to increase blood glucose levels, insulin is the only hormone known to have a direct effect on lowering blood glucose levels. The action of insulin are threefold. It promotes glucose uptake by target cells and provides for glucose storage and glycogen. Secondly, it prevents fat and glycogen breakdown, and it inhibits gluconeogenesis and increased protein synthesis. So at this time, we're going to watch a short video on the physiology of diabetes.
By the endocrine pancreas. Within the pancreas, specialized cells of the islets of Langerhans secrete glucose-regulating hormones into the blood. Alpha cells secrete glucagon, a protein hormone that maintains blood glucose by increasing the release of stored glucose, called glycogen, from the liver. Beta cells secrete insulin, which lowers blood glucose by facilitating the movement of glucose from blood into muscle, liver, and adipose tissue, and amylin, which slows the rate at which digested glucose enters the bloodstream. Delta cells secrete somatostatin. Somatostatin helps regulate blood glucose by decreasing gastrointestinal activity after eating. This delays intestinal absorption of glucose into the blood. To satisfy its energy needs, the body uses glucose, fatty acids, and other substrates as fuel. The brain relies almost entirely on glucose for its fuel. One way for blood glucose levels to rise is by food ingestion. Glucose not immediately used for energy is removed from the blood by the liver, which stores it as glycogen. When blood glucose levels fall, the liver's stored glycogen is broken down and released into the blood as glucose in order to maintain the blood glucose within its normal ranges. Blood glucose levels usually reflect the difference between the amount of glucose released into circulation by the liver and the amount of glucose removed from the blood by body cells. For health to be maintained, blood glucose levels must be kept within very narrow parameters. Cell membranes are impermeable to glucose, so they require a special carrier to move glucose from the blood into the cell. Insulin is that carrier. Insulin is either rapidly bound to peripheral tissues or destroyed by the liver or kidneys. Insulin has a half-life of approximately 15 minutes once it is released into the general circulation. Insulin lowers blood glucose levels in several ways. One way is that insulin facilitates the movement of glucose from the bloodstream into body tissues by binding to a target cell's membrane receptor. The insulin activates the receptors through a protein kinase messenger system, causing an increase in the number of glucose transporter molecules present on the outside of the cell membrane. The glucose transporter molecules, called GLUT4 glucose transporters, facilitate the diffusion of glucose into about 80% of body tissues. Within seconds after insulin binds to a membrane receptor of a susceptible cell, the membrane increases its uptake of glucose. This is particularly true of skeletal muscle and adipose tissues. Another way is that insulin provides for the storage of glucose as glycogen in the liver. When the supply of glucose is abundant, insulin activates the enzyme hexokinase, which in turn phosphorylates glucose. The addition of phosphate to the glucose molecule traps it within the liver cell. Approximately 2/3 of the glucose that is ingested with a meal is removed from the blood and stored in the liver as glycogen. Yet another way is that insulin inhibits gluconeogenesis, which is the building of glucose from new sources. This mechanism of action is a subject of investigation, but appears to involve the promotion of hepatic glycogen cycling, as well as the interaction of insulin with transcription factors. And finally, insulin also reduces blood glucose because it facilitates triglyceride synthesis from glucose in fat cells, while inhibiting the intracellular breakdown of stored triglycerides. The role of insulin in blood glucose control functions by means of a negative feedback cycle. The cycle begins with the body's blood glucose level increasing. In response to a higher level of blood glucose, the pancreas's beta cells release insulin into the blood. The insulin binds to insulin receptors present on most body cells. Once bound, the protein kinase messenger system causes an increase in the number of glucose transporter molecules, which then facilitate diffusion of glucose into the cell. When glucose is carried into the cell, it decreases the level of glucose in the blood, and this negative feedback inhibits further stimulation insulin release. Alpha cells then respond to a lowering of blood glucose by increasing the secretion of glucagon, which stimulates gluconeogenesis, the process by which the liver turns its stored glycogen into blood glucose, maintaining blood glucose levels between meals and during periods of fasting. Glucagon, because it counteracts the functions of insulin, is sometimes called a counter-regulatory hormone. Other counter-regulatory hormones include the catecholamines, which help to maintain blood glucose levels during periods of stress by inhibiting insulin release from the beta cells. Growth hormone, which decreases cellular uptake and use of glucose, resulting in an increase in blood glucose levels. And the glucocorticoid hormones, which stimulate gluconeogenesis by the liver. Fasting blood glucose levels are normally kept within a very narrow range. When blood glucose increases above its normal level, insulin secretion from the pancreas increases rapidly, then returns to baseline in 2 to 3 hours. A plasma glucose level higher than the normal fasting blood glucose level is defined as hyperglycemia. Hyperglycemia is usually caused by insulin deficiency or results from decreased cellular responsiveness to insulin. An abnormally low blood glucose level is defined as hypoglycemia. Hypoglycemia can be caused by fasting, or especially by fasting coupled with exercise, because exercise increases the usage of glucose. However, it is more likely to be due to taking glucose-lowering medications without enough food. Glucose is the energy substrate used most immediately by the body, especially the nervous system. The endocrine system performs the vital function of maintaining blood glucose levels within normal, narrow parameters. The beta cells of the pancreas produce the most important glucose-regulating hormone, insulin. An imbalance of insulin and other hormones can lead to abnormally high blood glucose levels, hyperglycemia, or abnormally low-leveled, hypoglycemia.
Now let's talk about the clinical manifestations of diabetes. It may have a rapid or insidious onset. In type 1 diabetes, signs and symptoms, they may come on suddenly. In type 2 diabetes, usually they develop a slower, more insidious. It may be detected during a routine medical exam or when a patient seeks medical care. It normally revolves over years before it even materializes. Type 1 diabetes is characterized by destruction of the pancreatic beta cells. It accounts for 5 to 10% of those with diabetes. Children and adolescents may present with DKA or diabetic ketoacidosis as the first sign of the disease. Others may have a slight elevation in the fasting plasma glucose that can rapidly change to hyperglycemia or DKA. Type 2 diabetes is a condition of hyperglycemia, and it accounts for 90 to 95% of the cases of diabetes. Most people with type 2 diabetes are older and are overweight, and it is a common occurrence in obese children and adolescents. So the symptoms of type 1 diabetes can start quickly in a matter of weeks, and the symptoms for type 2 diabetes often develop more slowly over the course of several years. Many people with type 2 diabetes have no symptoms, and they don't find out that they actually have the disease until they have diabetes-related health problems such as blurred vision or heart problems. So type 1 can occur at any age, but the peak onset occurs between ages 4 to 6 or 10 to 14 years of age. Type 2 usually occur after age 40, and it's also type 2 is higher in Black, Latino, Native American, Asian American, and Pacific Islander populations. So what are the physical findings? We displayed that earlier when you drew your silhouettes. Retinopathy, a cataract formation, skin changes, especially on the legs and feet, muscle wasting, and loss of subcutaneous fat, and that appears in type 1 diabetes. And obesity, especially around the abdominal area, that is seen in type 2 diabetes. Dry mucosa, mucous membranes, I heard that earlier. Decrease in peripheral pulses, I heard that earlier as well, which can lead to lower limb amputations. So the most commonly identified signs and symptoms of diabetes, they are referred to as the 3 polys. Polyuria is excessive urination. When blood glucose levels are sufficiently high, the amount of glucose filtered by the kidneys exceeds the amount that can be reabsorbed by the renal tubes, and this results in a large loss of water through the urine. Polydipsia is excessive thirst. The thirst results from intercellular dehydration that occurs as blood glucose levels rise and water is pulled out of the body cells. This is an early symptom, and it may be easily overlooked in patients with type 2 diabetes, especially if they've had a gradual increase in blood glucose levels. Polyphagia is excessive hunger. It usually is not present in people with type 2 diabetes, but in type 1 diabetes, it is the result of cellular starvation. Weight loss despite normal or increased appetite is a common occurrence in people with uncontrolled type 1 diabetes. And the cause of the weight loss is twofold. First, the loss of body fluids results from osmotic diuresis, such as vomiting and fluid loss and ketoacidosis. And secondly, weight loss occurs because body tissue is lost because a lack of insulin forces the body to use its fat and protein as energy. So, early signs and symptoms of hyperglycemia: frequent urination, increased thirst, blurred vision, fatigue, headache, skin infection. We identified all those on your silhouettes. These are symptoms that prompt a person to seek medical treatment, because most people with type 2 diabetes don't realize they have it. So late signs and symptoms of hyperglycemia is a fruity smelling breath, nausea and vomiting, shortness of breath, dry mouth, weakness, confusion, coma, and abdominal pain. So, hypoglycemia is the opposite of hyperglycemia. It's a condition where there is not enough glucose in the blood. And the early signs and symptoms of hypoglycemia is hunger, tremor, trembling, sweating, anxiety, irritability, pale face, heart palpitations, accelerated heart rate, tingling lips, dizziness and weakness. This is trying to compensate. It's a compensatory action. So late signs and symptoms of hypoglycemia is called diabetic shock. When the patient has problems concentrating, confusion, irrational or disorderly behavior, similar to being intoxicated, the inability to eat or drink. So the complications are seizures, loss of consciousness, and coma. So let's recap. So hypoglycemia symptoms are sweating, pallor, irritability, hunger, lack of coordination, sleepiness. So that's hypoglycemia. And hyperglycemia symptoms are dry mouth, increased thirst, weakness, headache, blurred vision, and frequent urination. So the diagnosis of diabetes is confirmed using laboratory tests that measure the blood glucose levels. Testing for diabetes should be considered for all individuals 45 years of age and older. Screening should be considered for young people at a young age, and people who are obese, have a first-degree relative with diabetes, or members of that high-risk group we just talked about, or have delivered an infant weighing more than 9 pounds. So the blood test, the first one is the fasting plasma glucose, and that represents the plasma glucose level after food has been withheld for at least 8 hours. And the casual blood glucose test, that's a random test, which is done without regards to food, time of the last meal time. Now the oral glucose test is an important screening test for diabetes. It measures the body's ability to store glucose by removing it from the blood. In people with normal glucose tolerance, the levels return to normal within 2 or 3 hours after they ingest the glucose load. But people with diabetes, they lack the ability to respond to that increased load. So therefore, their levels will remain high for a longer period of time. So the glycosylated hemoglobin A1C, now that's an important test as well. It provides an average blood glucose level over the previous 6 to 12 weeks. In uncontrolled diabetes, there is an increase in the A1C when the patient is poorly controlled. The ADA, or the American Diabetes Association, recommends corrective measures for A1C levels greater than an individual goal. So A1C goals are different based on the patient's risk factors. So if you have a patient with heart disease, advanced age, have episodes of severe hypoglycemia, that glycemic goal may be...
Ms. Gorman, I have a question.
Yes.
Sorry, about the A1C. You said it tests the blood glucose levels over the past 6 to 12 weeks? Is that what you said,
Yes,
6 to
the
12?
previous 6 to 12 weeks.
Okay.
So for that patient who has complications or greater risk factors, the goal may be 7.5 to 8% for the A1C. However, if there's a patient with less risk factors or no risk factors, the target will be 6.5 or less. Urine test is almost obsolete for many people with diabetes because the recommendation is that people self-monitor their blood glucose levels. Also, there are some new test devices such as the continuous glucose monitoring, the CGM. I know that you've seen the commercial where they're riding the bike and they scan to find out what their blood glucose levels are. That's a new test, and if I were you, I would research to see what other new therapies and tests are available for diabetes. This type test, they have small implanted catheters in the subcutaneous tissue, and that is what provides the continuous and frequent samples. So, what are the acute complications? There are 3 major acute complications. We've already talked about hyperglycemia and hypoglycemia. So, diabetic ketoacidosis is characterized by hypoglycemia, hyperglycemia, ketosis, and metabolic acidosis. It is a life-threatening condition of uncontrolled diabetes. It primarily affects patients with type 1 diabetes, but it also can occur in patients with type 2 when they have severe stress such as sepsis or trauma. And they all are life-threatening conditions they demand immediate recognition and treatment. So it's important as a nurse to know the signs and symptoms and complications. So the chronic complications. Over time, high blood glucose leads to problems such as heart disease, stroke, nephropathy, which is your kidney disease, retinopathy, eye problems, neuropathy, your nerve damage, and foot problems. So diabetes management. The desired outcome is for normalization of blood glucose levels so that they will prevent short and long-term complications. Also, treatment plans involve dietary management, exercise, and anti-diabetic agents. Some people with type 1 diabetes require insulin therapy from the time of diagnosis. So that's a major difference. Type 1 requires insulin from the onset or diagnosis. However, weight loss and dietary management may be sufficient to control persons with type 2 diabetes. But among the methods to achieve these treatment goals, education and self-management and problem solving for the patients is primary and necessary. It's the cornerstone of management, patient self-management and education. So individual treatment goals should take into account the person's age and other disease conditions, the person's capacity to understand and carry out the treatment regimen, and the socioeconomic factors that might influence compliance with the treatment plan. Optimal control for type 1 and type 2 diabetes is associated with prevention or delaying chronic diabetes complications. So, what are the nursing responsibilities for teaching patients and family? What do you think the primary thing would be for you to teach the patients and their families as for nursing? For nursing responsibility, you have a patient with diabetes, type 1 or type 2. What do you think your primary responsibility would be to teach? Yes.
When to take the insulin? How to take it?
Correct, how to take it.
What it's used for the short acting and long acting insulin. So when you to use the short versus the long.
Good, that's correct. Anything else?
Their diet,
Diet,
exercising.
exercising is a good one because it affects insulin sensitivity. Anything else?
Self-assessment of skin conditions? Self-assessment of skin conditions, like Some words.
You can carry a sword, you can.
That's correct. So I think you all called them all out. Teach them about their diagnosis and the treatment plan, the technique for administering insulin, medication, and what the adverse reactions, when to notify their health care provider. We have a lot of patients who utilize the ER opposed to their primary care physician. Prescribed meal and exercise plans, signs and symptoms of infection, hypo and hyperglycemia, neuropathy, treatment of hypoglycemia, self-monitoring, eye exam, management during illness. I didn't hear that one. Because remember, stress increases your glucose levels. Illness would cause your system to be under stress. So let's watch a video, a short video that talks about monitoring your blood sugar because it remains the standard of care, self-monitoring.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video we're going to go over how to check your blood sugar. As a nursing student, you're going to have to learn the skill of how to check a blood glucose using a glucometer. As a nurse working in the hospital setting, you will be checking your patients' glucoses, especially your diabetic patients. Now, if you're watching this video because you've been newly diagnosed as a diabetic, or you've been experiencing bouts of hypoglycemia, meaning your blood sugar drops, and you bought a glucometer just to monitor your blood sugar, this video will help you how to do that, because I'm actually going to show you myself of taking a blood sugar, how to do it. And I'm going to go over all the supplies with you. Now, check out my other videos on how to do a quality control test on your glucometer, how to poke your finger with a Lancet, and how to load your Lancet device if you're confused on any of those things. So let's get started. This is a basic home glucometer testing kit that you can get. Now, nursing students, your glucometer in the hospital will probably look a little bit differently, but they all work the same. Now, if you were newly diagnosed with diabetes and you need some advice on getting a kit, I really recommend that for your first kit that you get a kit that comes with a meter, comes with test strips, a quality control, your Lancet device, and your little Lancets. Because this will help you when you're first starting out, and it'll have everything you need. And they usually come with a little carrying case, a little book log, and you can have all your extra supplies. So let's go over what's in this kit. First thing you have are your testing strips. Each monitor comes with a specific testing strip. So when you run out of testing strips, you have to buy the test strips that go along with the monitor. And please note, this is so important. Once you open up these test strips, they're only good for 4 months, okay? So right on the bottle when you open them, and they're only good for 4 months. And make sure you check the expiration date when you buy them to make sure that they aren't expired, because if you use expired test strips, you'll get the wrong readings. And your test strips look like this.
My 10-year-old little girl had to pick somebody that she looked up to that was a hero. And she had picked me because she said, my mom is a hero.
This part will go into the monitor, and then this part will collect your sample, and we'll go over that here in a second. Next, we have the meter itself, so small but it's very handy. They've came a long way. They used to be very big. Usually you can hit the on button right here, whatever your monitor says. Always read your glucometer monitor settings because they all work a little bit differently, but this one works. You can hit this button right here or just put in the test strip and it comes on itself. We have our quality control. You'll always want to get some type of quality control testing, because when you first get your monitor, you want to do a quality control test just to make sure it's calibrated right. And then you'll want to perform it, you know, every other couple days, and especially when you change out your strips. And another thing that is important to note, this solution is only good for 3 months from the time you open it, and it expires after that. So keep that in mind. Next, what we have is a Lancet device. You will need this so you can actually poke your finger. What you do is you unscrew that, you load the Lancet in there, and you engage it, and then you poke your finger, and we'll go over exactly those steps on how to do that here in a second. Next, you have your Lancets. These right here are 30 gauge, and I just want to show you the different gauges. You can get various gauges of Lancets. You can get 27, 28, 30, 32, and 33. Basically, what it is the size of the needle, and a 30 gauge is usually sufficient enough. The lower the number, the bigger the needle. So if you have really thick skin, you might want to go with a bigger gauge, but usually 30 is sufficient enough for people. And then this is just a little test log. A lot of monitors are fancy and they'll keep it stored in as a memory, and your doctor can just upload it, but this one is just basic. And you want to record what your blood sugar is so you can keep track of it, take it to the doctor with you, so they'll be able to see what your blood sugars have been reading. So now, and also some alcohol prep that you want to clean your fingers with. So now let's get ready and check our blood sugar. The very first thing you want to do before you check your blood sugar is wash your hands with warm water, because that's going to increase the blood flow to your fingertips. Because when you check your blood sugar, the best place generally is to check on the fingertips. Some devices say you can use your forearm, your palm, but this device specifically recommends fingertips. So after you wash your hands, you're going to get your supplies, and what I like to do is get everything set up. So very first thing, it doesn't really matter what order you do it in, just as long as you do it. We are going to prime our Lancet device. So in order to do that, the Lancet devices look a little bit differently, but they work the same. They generally twist off right here, and you're going to take the cap off, and this is where your Lancet is going to go. Your Lancet typically has these little grooves around it, and it will fit snugly inside this part. Now I just want to show you something. Whenever you push this part in, notice it engages the needle. Now whenever you're ready to poke your finger, you're going to hit this button, and when you hit this button like that, it takes the needle and pokes it in your finger. So what we want to do is just get that Lancet inside the device and line it up with these grooves and just push it in snugly. And we're going to go ahead and engage that. And now we need to expose the needle. The needle's been protected by this little area right here. So what you do is just simply twist it off. And if you can see right there, it's exposing your needle. Now we're going to put the cap back on, and we're going to just twist this on right here. And we are almost ready to go, but if you notice, can you see these little numbers right here on the device? This is how deep the needle is going to go into your finger to draw blood. So here's generally the rule. You'll want to read the instructions on your Lancet device, but typically you want to use a 1 to 2 setting if you have really thin skin, a 3 to 4 setting if you have just average skin, and a 5 or 6 setting if you have thick callous skin. So what I like to say is 1 to 2, if you know, women, we tend to have thin skin if you're on corticosteroids or your hands bruise easily, probably 1 to 2 is sufficient enough. 3 to 4, typically young people have a lot of collagen in their skin, is average thickness. 3 to 4 is good. But if you're a man who works a lot with your hands, even women, and you have calloused hands, a 5 or 6 is definitely where you want to go, because you want to be able to draw enough blood in one stick. So here, I am just going to slide mine to a 3, because that's sufficient enough on me. Okay, so we have our Lancet device ready, and we can't hit this button yet because remember the needle will go off. So we're just going to set that aside. Now we're going to get out our test strips. And remember, these were good for how long? 4 months. And what we're going to do, I'm going to let you look at the test strip. Always read your device's instruction, but on this device, This part goes into the monitor, okay? And then this little part is where it's going to actually suck up the blood sample. So what we're going to do is we're going to slide it into this part of the monitor, and it'll turn the monitor on for us. Okay, see how I did that? Okay, now we are ready to poke our finger and see what our blood sugar is. So what we're gonna do, you want to clean the finger off with some alcohol prep. And massage on your finger, because this is getting all the blood flow to your fingertip, and you're gonna use the pad of your fingers, and we're gonna go right on the side of the finger, okay? Not in the middle, but on the side. That's typically where those little capillaries are, and you get a really good blood draw from that. So I'm massaging on that. I'm gonna clean the area with alcohol, let it dry thoroughly. Now, after I poke the needle into my finger, I'm gonna wipe off that first drop of blood, because there's still some alcohol in it, and it could dilute the little specimen that you're giving the monitor and throw off your reading. So always remember to do that. Okay, so what we're gonna do is I'm gonna line it up, and you're gonna see a small drop of blood. So if you're squeamish with blood, you might wanna not watch this part. And get my first sample, and I'm gonna wipe that off, and then I'm just gonna squeeze a little bit more. You don't really have to squeeze too hard, it gets enough, but you want a good size drop. And then you're gonna put it on the end of the monitor like that, and it sucks it up, very neat, and we're gonna see what the reading is. And then hold pressure where you poked your finger.
Okay. I think that's the gist of it, y'all. So now, what we're gonna do, we're going to assess what we've learned again. So you are already in groups. I need one device per group. Oh, okay. Let's have a 10-minute break.